In this video, we're going to be talking about the pituitary gland, which is also known as the hypophysis, and it is sometimes called the master gland. It's called that because it happens to control most of the other glands inside the body. As this slide says, this gland is pretty heavily protected by the bony protuberances of the sella turcica of the sphenoid bone. So it's an important little gland, even though it's really super teeny tiny, really important. Why is the pituitary gland divided into two halves? This picture helps to explain that better than most anything else. It's divided into two halves because it is made of two completely separate tissue types. The anterior pituitary gland up here is made out of epithelial tissue. It is a true endocrine gland. It releases and produces several different types of hormones. The posterior pituitary gland, on the other hand, is really just an extension of the hypothalamus. It does not actually produce hormones. Instead, it stores hormones and then releases them when the hypothalamus tells it to release those hormones. How does the hypothalamus relate to the pituitary gland? This picture also shows us that. So this is the hypothalamus. So the hypothalamus is just superior to the pituitary gland. The hypothalamus is directly connected by axonal connections to the posterior pituitary gland, so direct axon connections. It is also connected by this vascular connection. So there's a little capillary bed that's called this hypophyseal portal system that connects both halves, really, of the pituitary gland up to the hypothalamus. The hypothalamus is so concerned with regulating homeostasis that it needs access to the bloodstream to know things like, do you have enough food? Do you have enough water? Is your temperature what it's supposed to be? Just everything. What is going on there? And then, because the pituitary gland controls a lot of the other glands that controls those things, it needs to be able to release and pick up those hormones to distribute to those other glands. And so that little blood network is going to help us do all of those things. So direct nervous system connection and a blood connection that's going to help us communicate and distribute things very well throughout the body. Okay, next. There is a stupid mnemonic that is going to help you remember the hormones that are secreted by the anterior pituitary gland. The stupid mnemonic is flat pig. Flat pig. Okay, so here's what this means. The F is for follicle stimulating hormone. I'm going to abbreviate. The L is for luteinizing hormone. The A is for adrenocorticotropic hormone, or ACTH for short. The T is for TSH. Okay. The flat part right here, these are all tropic hormones. I'm going to define those on the next slide, but tropic hormones are the hormones that control all the other glands in the body. So these are the hormones that help to make the pituitary gland the master gland. Okay, the P is for prolactin. The E is actually for endorphins. I don't consider those hormones. I consider them neurotransmitters, and so I'm ignoring those. The G is for growth hormone. Prolactin and growth hormone, those are not tropic hormones. Those are standard hormones that help do regular old hormone things. And so they are still produced by the anterior pituitary gland, but they are not tropic hormones. So flat peg gets you the 6 hormones produced by the anterior pituitary, helps to show you why it's the master gland. This does not show you the posterior pituitary hormones, just the anterior pituitary, but it also shows you why we're going to be spending so much time on the pituitary gland. Okay, coming back to the tropic hormones. Tropic hormones are hormones released by one gland that help to regulate another gland. Perfect example of that, thyroid stimulating hormone stimulates the thyroid gland to do what the thyroid gland is supposed to do. But all of the flat hormones and flat peg, those were all tropic hormones. Okay, so at this point we're in the tables. We may not be in the same order sometimes, but you're going to get what you need. If you write down the stuff that's in yellow on the slide, then you're pretty much going to get what you need to help you study. Sometimes I will talk about diseases here. Sometimes, especially when we're talking about the tropic hormones, I won't talk about those diseases until we get to the gland that was actually being stimulated. So that's why I have X's in some of those boxes at this point. One of the things that I'm going to recommend that you do is make yourself your own flashcards and put the name of the hormone on one side and the effect on the other side so that you drill yourself really hard on what those hormones are going to do. Because if you know that, you know basically everything that you need to know. Because if you know what a hormone does, then you can logically think for yourself what will happen if you make too much of that hormone. That gets you all the disease symptoms for hypersecretion. If you know what the hormone does, you get all the disease symptoms for if you have hyposecretion of that particular hormone. And so there's a lot of logic and reason that goes in this chapter, but you got to memorize some basic stuff, and that's why I'm going to recommend flashcards to get the basics down. Okay, so to start us out, growth hormone. The basic effect of growth hormone is in the name, growth. So remember the parts of your body that grow the most. Your long bones have your growth plates, aka epiphyseal plates. That's where they are predominantly going to have the most receptors for growth hormone. And so that's where this hormone is going to have the strongest effect on bones. However, your short bones, flat bones, or regular bones, they get stimulated all over because remember, they don't do growth plates like your long bones are going to have. Skeletal muscle, tons of receptors for growth hormone. Most of the cells of your body are going to respond to growth hormone, but again, they've got to have receptors in order for it to work. And so stimulates growth by stimulating mitosis is how that's going to work. If a person secretes too much growth hormone, hopefully, obviously, that means they're going to get to be too big. So there's actually going to be two diseases that we're going to talk about here, and it depends on whether or not that growth plate has sealed up. So here's where you got to remember your AMP1. Remember that your long bones stop growing when you hit somewhere around the age of about 25. After that, your long bones are done, which means you could secrete all the growth hormone you want. Your long bones are not going to keep growing after that point. But your short bones, flat bones, irregular bones, they never had a growth plate. They never seal up. They will still continue to grow. So if you secrete too much growth hormone as a child, when your growth plate is still active, you're going to have gigantism, and you're going to be exceptionally tall and proportional. Your long bones and your short bones and your flat bones and your irregular bones, they will all be much larger than a regular person's would be, essentially. This was the tallest person to have ever lived, and I always forget his name. It's like Wardlaw or Wardor or something that starts with a W, and I think he was like 8 foot something or other. But yes, he had gigantism. The flip side of that, if you make too much growth hormone, once the growth plate has sealed up, your long bones won't grow, but your short bones, flat bones, irregular bones, they will continue to grow. And here's the problem with that. I'm showing you a nice deformity of the feet, and yes, that's uncomfortable. It can make walking very unpleasant or difficult, but here's the crux of this matter. You've got to remember your ribs are flat bones. Your ribs are going to keep growing. And what are your ribs attached to? Your sternum. As your ribs grow, they're going to push your sternum back. And what's right behind the sternum? Your heart, your lungs. And so this is going to kill you. Hypersecretion of growth hormone as an adult leads to acromegaly. Acromegaly is fatal. So people should not be playing around with growth hormone as an adult. It will literally kill you because it crushes your heart and lungs. It plummets your blood pressure and you literally cannot breathe and you die. And so, yeah, don't play with growth hormone is the moral of that story. Hyposecretion. So if it helps you grow, if you don't make it, you won't grow. And so that leads to one form of dwarfism. There are lots of reasons why a person might be a little person. This is only one reason. This happens to be the most treatable reason why a person might be a little person. All we have to do to fix this is give them growth hormone, and they will grow normally when we give them therapeutic doses of growth hormone. So you very rarely see this in the United States, but if you go to countries where the hormone is not available, you will still find that there. This is, like I say on the slide, just a side note. There are people who will go online and buy themselves growth hormone because they think it's going to help them play basketball, or they think their kid is too short, or any numbers of really stupid things. Now, If you have a medical reason for growth hormone and your doctor's prescribing it, that's one thing. Fantastic. But if you're doing it just because you want to be taller, remember what I said earlier. It will literally crush your heart and kill you if you overdose on growth hormone. But growth hormone does also play around with your blood sugar levels. It increases your blood sugar level, and it can make it look like you have diabetes when you do not have diabetes. So your doctor might end up thinking that you are pre-diabetic or diabetic when you really don't. And so that is something to also keep in mind. Don't use growth hormone if you don't need it. Okay. Thyroid stimulating hormone, also known as thyrotropin, does exactly what the name says it's going to do. Stimulates the thyroid gland to do what the thyroid gland does. We will talk about the diseases when we talk about the thyroid gland. Adrenocorticotropic hormone does exactly what its name suggests, but you got to break down the name in order to figure it out. So adreno means adrenal glands. Cortico means cortex. So the adrenal gland is divided into a cortex and a medulla. Cortex is the outside part. Tropic means tropic. So this is the tropic hormone that stimulates the adrenal cortex. It stimulates the adrenal cortex to do its job. We'll talk about the diseases when we get to the adrenal cortex. The two gonadotropins, FSH and LH. FSH is follicle stimulating hormone. It stimulates the follicles, which exist in ovaries. It was named based on what it does in women. Men don't have follicles, but it does work in men. It stimulates men to produce sperm faster. We will talk a little bit more about FSH when we get to the reproductive chapters at the end of AMP2. Luteinizing hormone, LH. It triggers ovulation in women. In fact, ovulation test kits actually test for what is known as the LH surge, which occurs the day before ovulation. In men, it really just triggers an increase in testosterone. And again, we'll talk more about LH later, so don't worry about diseases for FSH or LH. Prolactin. Hopefully prolactin makes you think like, yay, milk, because prolactin helps a person to make milk. It is usually only produced when a woman is about to have a child and has recently had a child and is in the process of trying to feed said child. So it makes the mammary glands actually produce the milk to feed the baby. Hypersecretion of this can happen in both sexes. There are numerous documented cases of men actually producing and secreting milk. Men tend to find that very stressful when that happens, and it can be treated with mastectomies or sometimes hormone blockers. It just kind of depends on which way we end up needing to treat that. Hypersecretion in women is also potentially problematic. There are women who end up producing so much milk that they donate that milk to area hospitals to feed babies whose mothers maybe can't produce that milk. In fact, in Cleburne, there was a woman, and I always end up forgetting, it was like an obscene amount of milk. She was making like 40 gallons of extra milk a week or something, just an obscene amount. But she kind of saw it as a blessing because she got to donate that milk to area hospitals. But I can't imagine that that would feel comfortable to feel that level of engorgement in the breasts. So we do have some treatment options for that. But essentially it just means you're going to make a lot of milk if you hypersecrete prolactin. Hyposecretion is really only going to be a problem if you are actively trying to breastfeed, because what it would mean is you can't actually breastfeed your child because you're not going to release milk. The side note that I always make in this case, as I'm talking about this, is breastfeeding is not nearly as simple as women tend to think it is after they have had their babies, especially their first babies. Babies have trouble latching on. Moms have trouble with nipple size, nipple placement, nipples protruding like they're supposed to. What you would not believe how many nipple problems there are out there in the world of women. There's problems with milk not coming in, milk not letting down. There's all sorts of problems. If you are having that problem, or you are working in labor and delivery and you're seeing a mother having those problems, every hospital that I have ever been to has lactation counselors on standby that will come and help, and they are like magicians. You could sit there and try to work with your baby for like 8 hours to get your baby to latch on, and they won't do it. The lactation counselor will come in and poof, your baby is on and feeding in 30 seconds. I don't know how they do it. They really are magical, but they are there. And so do keep that in mind, that hospitals have that available. Okay. Now we're going to switch over to the posterior pituitary. There's only 2 hormones being secreted by the posterior pituitary, so I don't have a stupid mnemonic for these. Oxytocin is the first one. So again, I'm out of order here on the table, but oxytocin has a lot of different impacts. It does also get secreted in men, but we're going to talk about what it does in women, specifically in pregnant women. Oxytocin is the primary driver of uterine contractions during labor and delivery. It is the hormone that it gets released in positive feedback, which we talked about a little bit last semester. Remember, positive feedback amplifies a response instead of negating it. So instead of like the contraction getting worse and getting better, it gets worse and worse and worse and worse until the baby is out. So what happens is oxytocin gets released, the baby and the contractions get stronger, and the baby's head pushes against the cervix. That causes you to release more oxytocin, which causes stronger contractions, which pushes against the cervix more, and so on. And it keeps going again until the baby actually gets pushed out. That's how contractions and positive feedback and oxytocin are going to work. So the oxytocin triggers the uterine contraction. In addition to that, oxytocin also triggers milk release, or milk ejection is how I phrased it on this slide. So the prolactin helps you make the milk. Oxytocin helps you release the milk. So you do need both of those two hormones to help you actually feed the baby when we get to that point. Don't really have any diseases that I wanted you guys to get for oxytocin, but I did want to mention if a woman has a slow labor, we do have synthetic oxytocins. Pitocin is the most common one where we can give them so that we can get the labor going like it's supposed to. So if you've heard of Pitocin, it's the same basic thing as oxytocin. All right. Last one that we're going to talk about is antidiuretic hormone. And I want you guys to star this, highlight it, circle it, because we're going to talk about this in at least 4 chapters as we go through AMP2. It is a very important hormone. You release it every single day of your life, assuming that you are alive and well, and yet you have no idea about it or what it does. Antidiuretic hormone, abbreviated ADH, is also known as vasopressin. It's called vasopressin. Vaso means blood vessels. Pressin means contraction, because it does cause the blood vessels to constrict. So it does have a direct impact on your blood pressure. It's trying to increase your blood pressure. Okay. One of the things that helps me to remember what antidiuretic hormone does is to know that diuresis is urine formation. So antidiuresis is the opposite of urine formation. So antidiuretic hormone tries to stop you from making urine. So if you have not been drinking for a while and you are starting to get dehydrated, your body will make ADH to stop you from making urine, because you don't want to pee the water out if you are starting to get dehydrated. What will happen is you will start to reabsorb the water from your urine back into your bloodstream so that you can keep your blood volume up, so that you can keep your blood pressure up, so that your kidneys don't fail and you don't die. That is what antidiuretic hormone does for you. Okay. This is more sort of an aside. A big part of the reason why people get hangovers when they drink is that alcohol directly inhibits your ability to release ADH. So when you go to the bathroom, when you're drinking alcohol, you're not just peeing out your alcohol, you're peeing out an excess amount of water. So you get more dehydrated when you're drinking alcohol than you drink regular stuff. That's one of the reasons why they always recommend drinking, like drink your beer, then drink a water. And that will help you not get as bad a headache the next day. Okay, if you work in medicine for any length of time, you will give a diuretic to somebody at some point. Diuretics are drugs that make you pee more. They are given to people who are in congestive heart failure, who have critical edema, who have any number of different problems where they are accumulating fluid when they should not be accumulating fluid. Diuretics just make you pee a lot. So if that helps you to remember what antidiuretics will do, awesome. Diuretics make you pee more, so ADH will make you pee less. ADH is just all about helping you conserve fluids to keep your blood pressure up so you don't die. Okay. Hypersecretion of ADH is really just going to cause high blood pressure. And hyposecretion is more of a problem. So here's where we get to the fun of, there's more forms of diabetes than you're familiar with. In the old days, before there were computers and test strips, you get the fun, gross story of a symptom of diabetes is polyuria. Polyuria means that a person is peeing excessive amounts. In the old days, it would be a nurse's job, be glad you don't have to do this now, to drink the urine and find out if it tasted sweet or if it just tasted like water. If it just tasted like water, the fancy word for that is it has no taste, so it's insipid. So diabetes insipidus means the person's peeing a lot, but there's no sugar in the pee, so it's not the same thing as diabetes mellitus, which is the diabetes that everybody thinks about the second you say diabetes. So this is a different form of diabetes than what you're thinking about. It has nothing to do with insulin. It has nothing to do with blood sugar. It is all about blood pressure, and it is all about ADH. Diabetes insipidus means that you're peeing a lot because you do not release ADH like you're supposed to. Because you are peeing so much, you're going to be incredibly thirsty because you're going to be incredibly dehydrated. So that's going to trigger your thirst response. So you're also going to have another big P word called polydipsia, which is incredible thirst. The treatment for this is honestly just drink enough to keep up with the fluid that you're losing. If it's bad enough, we can give you some synthetic ADH for you to take to try to keep up with the problems. Most of the time, this happens as a result of a person hit their head hard enough that it damaged the pituitary or the hypothalamus connection. And so sometimes this gets better after the swelling goes down in the area. You just have to watch them while they're recuperating. But most of the time, it tends to get better on its own, essentially. All right. I think that's all I wanted to do, aside from I already said this, but I'm not kidding when I say, yes, this was really how they used to do this back in the old days. So remember, diabetes insipidus has nothing to do with insulin or sugar at all. That is where I'm going to stop this one because the pituitary gland had a lot going on. So I hope that helps you.